Welcome everyone to today's webinar, How Two Health Systems Are Transferring Their Behavioral Health Services Line. On behalf of Beckers Healthcare, thank you for joining us. Before we begin, I'm going to walk you through a few quick housekeeping instructions. So we're going to begin today's webinar with a presentation, and then at the end we'll have some time for some question and answers. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you'll see on your screen. If at any time you don't see your slides moving or have trouble with the audio, you can try by refreshing your browser. You can also submit any technical questions into the Q&A box, as we are here to help. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. With that, I am so pleased to welcome today's speakers. We have Andy Flanagan, Chief Executive Officer at Iris Telehealth, Kathy Cox, Ambulatory and Virtual Channel Chief Operating Officer at Texas Health Resource, and Holly Mintz, Ambulatory Care Chief Medical Officer at Elliot Health System. Andy, Kathy, and Holly, thank you so much for being here today. I'm going to now turn the floor over to Andy to kick off today's discussion.
Thank you very much. Welcome, everybody. It's going to be an exciting conversation today. We have two leaders that have led their organizations through an enterprise transformation in their behavioral health service line. Obviously a daunting task, and we're going to spend most of our time actually hearing them talk about some of the challenges, the opportunities, and the future of their respective journeys. To begin, I'd love to ask each of our panelists to introduce themselves, and Dr. Mintz, if you could kick us off, please.
Hi, everybody. My name is Holly Mintz. Thank you so much for having me. I am a pediatrician by training. I practice in Manchester, New Hampshire, and have been in this region for approximately 28 years. Part of the reason that I was motivated to be in an administrative role was to help improve access to behavioral health care. And it's been quite the journey, and I'm excited about the things that we're doing here. So I look forward to speaking with you all today.
Thank you. Kathy?
Sure. Good morning, everybody. Thank you so much for having me. I'm super excited to be here today. I have been with Texas Health Resources for a little over 30 years, and my background is a little bit diverse. I have about a third of my career has been in consumer experience, about a third in operations, and the last third in IT and innovative technology. So it's all giving me a really good, very good rounded education as to how healthcare works. My current responsibilities include a variety of resources and assets. Primarily related to this call, I have responsibility for our new virtual behavioral health capability, our employee assistance program, and also a residential treatment center down in Mansfield, Texas. In addition, I also oversee our urgent care centers, as well as all of the other virtual care delivery assets that we have. Thanks for inviting me.
Great. Thank you both, Kathy and Holly. Let me just frame the topic to begin with. So in approaching this basic, kind of position here today, speaking with both Holly and Kathy, their systems respectively identify the scale of the problem. We know behavioral health access is a universal problem, both in the United States and globally. And so as two leaders in their regions, they each took an enterprise approach to moving past point solutions and thinking about the holistic behavioral health service line, the community needs, as well as the inpatient and ED requirements. The strategic and the economic case for making that decision is not easy. And for many of you on this call, on this line, you know that you're dealing with ourselves. We work with health systems across the country. Everyone struggles with this question. No money, no mission. So we understand the importance of it. And then, the punchline here is that the systems, the Elliot and Texas Health Resources have been successful because of their enterprise alignment, the enterprise buy-in, and the transformational approach. So that lens has created kind of a best practice, if you will, for us to learn from. And that's what we're going to do for the rest of the call. So I'm going to ask the first question, which is, what challenges did you face in your communities regarding behavioral health that led you to realize that you needed to make behavioral health as a strategic priority as the leadership team? And Kathy, perhaps you could lead us off.
Sure. You know, I don't know that it's any secret to anybody if you're reading the newspaper that North Texas is one of the largest growing areas in the country. Some of the cities here in North Texas are literally in the top 5. So I think that's one really important component, is that more and more people are moving here every day. And we know that mental health diagnoses in the United States as a whole increased about 40% in the last 4 years. And a lot of that is because people are more apt to actually ask for help, which is a good thing. Unfortunately, we have a significant shortage of providers in this area. Texas Health happens to be one of the health systems in this community that actually has a very robust inpatient behavioral health service line across multiple hospitals within our system. However, we didn't have any low acute services as part of our portfolio, and depression's at an all-time high. There's a lack of resources for youths and seniors, and right now, what we know is in this community, if you are looking for low acuity behavioral health, you could be waiting anywhere from 6 to 10 weeks for treatment just for a first appointment. And most of the providers in this area are cash pay only. So when we think about Texas Health and how we approach this, the idea was, could we actually provide a longitudinal offering for the people in our community that would allow them to be treated for behavioral health within an integrated network of providers across our primary care physicians and our hospitals. And so that's how we actually approached it here in North Texas.
Thank you, Kathy. Holly?
So in New Hampshire, we also have a shortage of resources, and the system that I work for has always been committed to behavioral health. We are one of the few hospitals in the state that has an inpatient behavioral health unit, also a gero-psych unit. But we have never had enough resources, of course, as we need. And one of the things that I, as a primary care provider, has always appreciated is that, you know, if I have a patient with, you know, a cardiac issue or a pulmonary issue, I can get them right in. But if a patient has a behavioral health issue, I always felt like I was kind of printing off a list of potential providers that they might be able to see and giving them that list. And although I wasn't saying that, I felt like I was saying best of luck. And so what we agreed as an organization is that we needed to do better. The need is clearly there, especially since COVID, but this need existed even before COVID. And we looked at the number of behavioral health calls that our triage nurses were receiving. And we just knew that we needed to do better. We needed to do better in placing people with therapists and better understanding what they need as far as either medication management or therapy, and really making sure that it was not acceptable to have a 60-day wait in between a referral and actually even an intake process, let alone seeing a provider. So we chose that we really needed to focus on decreasing the time to care, which we knew would benefit the care as a whole.
Fantastic. You know, it's fascinating that you are virtually the other side of the country, north and south, and, you know, a very similar, you know, challenge, if you will.
I would argue, Andy, probably it's a similar challenge to a lot of people on this call, no matter where you are in the country.
Mm-hmm. So let's dig into this theme. So, of course, everyone's saying that's fantastic. The social mission, strong match across the country, rural, urban, the empathy for our families' journeys. Every family's been touched by mental health, behavioral health. So let's talk about the money. How do you fund it? You each, in your own way, led your management teams, and part of your senior team's journey was, what's the ROI? How do you fund this? Is this a top 5 priority or top 3? So can each of you, and maybe we can reverse, and Holly, you can lead us here. How'd you think through that? How did you get there?
Well, as a systems approach, I think we all are aware that early access to treatment is going to improve outcomes. So if you look at from a system approach, if you're able to intervene with a behavioral health issue early, you helped keep people out of the emergency room. You helped to prevent hospitalizations. But really, when we dug down, what we learned is that our triage nurses were accepting about one out of every 5 phone calls that they were receiving was about behavioral health. And the average length of time on that phone call was around 27 to 30 minutes. So that's all kind of uncompensated time. In addition to the fact that the triage nurses were feeling extremely burned out from managing behavioral health because they didn't feel like they were able to do the full and complete intake that they needed. And so patients would end up being triaged and then squeezed in for something that might have been going on for a couple months. So what we looked at is if we were able to convert those triage calls into actual full intakes from a licensed social worker, not only would the patients benefit because they would have a full evaluation, but that full intake is actually billable. And so we were able to cover some of the cost of investing in increased hiring of providers by actually converting those triage calls to a full intake. So there's a very brief triage, just assessing the potential presence of a crisis. But then those patients are basically have an intake and transferred to our intake process. We've been able to do it within 1 to 2 business days, and that visit is actually billable. And so that's been able to cover some of our cost, which has really been, I think, a benefit for everybody and helped to make this new program that we've initiated sustainable.
Mm-hmm. Yeah, similarly, Holly, I will say, we're thinking about things very similar ways. We also learned about some of the opportunities there where we could have some additional billable services that we hadn't considered before. I think the other thing that we looked at as we think about investments in behavioral health is traditionally for our system, behavioral health was more of a mission-based service line, right? It's very, no surprise, everybody knows this. It's poorly reimbursed. There's not a lot of margin here. And lots of staffing challenges that we have to face. A lot of fighting on the other end after you drop the bill for things being denied. So it is definitely a service line that's not really at the top for reimbursement. But I think that one of the most important things that we're thinking about is how it applies to the overall, all service lines. And I think the way that we're looking at it as we think about this investment is that rather than thinking about behavioral health as a service line in and of itself, we're thinking about it as a component of all the others, because what we know is that our chronic patients, whether they are facing CHF challenges or COPD or hypertension or diabetes or you name it, behavioral health ends up being an underlying challenge for these patients. And the benefit for all of the service lines comes when we can address those mental health challenges of those patients. And so I think that as we think about it and how we invest, and we're looking also at ways to get it reimbursed within grants or other types of opportunities where, whether it's the government or other types of foundations who are interested in mental health, that we can reach out and think about the way we provide this within other service lines in a different way and achieve some other funding opportunities that will help communities or certain patient populations that will benefit the whole. So that's some of the different ways we're thinking about the investment. Does that help, Andy?
Yeah, that's super powerful. The business case creation is it's always complex, right? Especially in today's environment, post-COVID, the procedure pressure that's happening, the dynamics still recovering from COVID. It is a counterintuitive investment, right? Because it is such a long tail problem. It doesn't show up in the payments as sometimes it's outside of value-based care arrangements. But to your point, Kathy, it exactly correlates to so many aspects. And Holly, your comment, the emergency department, and we hear these as bright lights and problems. Unlocking that into a holistic solution is somewhat counterintuitive, right? It's hard. So let's talk a little bit about, the definition of success, even maybe looking out a couple of years. So you make this investment, you go through an implementation, you stand it up, takes, I don't know, maybe a year or so. Talk about your respective experiences and how you think about success, maybe years 2, 3, 4, and 5, if you can.
I'll go ahead and start. That's a really, although I shouldn't have, because I'm getting ready to say that's a really hard question. And depending on, if any of my colleagues are on the line, whether they're a finance officer or one of our behavioral health leaders, every one of us would probably answer this question differently. But I think when I'm thinking about it, and when I'm thinking about it from a system standpoint, I think success for us 3 to 5 years is, number one, that behavioral health services are hardwired into the patient journey longitudinally, soup to nuts, right? And within every service line, within every type of journey that a patient goes through. So I think that's number one. The second thing for us is that behavioral health and our employed physicians have a very strong relationship, so that whether it's within our virtual psychiatric practice or whether it's in our inpatient space or outpatient space, rather than it be two different areas, that these groups are working together for that patient population. Because I think that traditionally you have a lot of primary care physicians or specialists who are dealing with their patients' mental health issues over here, and it's very disjointed. Now that we've created a much more integrated approach, there's an opportunity for those things to work together. And if we are collaborating across the organization for these patients, I think that's a big success area. And then finally, because I am a chief operating officer, the service line has to ultimately sustain itself. And how we do that and how we measure value across a lot of different areas, I think, is really going to be important to achieve that.
Yeah, I think that for me, looking at our system, what does success look like? First of all, at the heart, it's that behavioral health disorders are treated as they are, as every other disorder. So, for instance, when somebody is having a heart attack or a stroke, they're not boarding in the ER for 10 days waiting for a bed, right? So how do we ensure that we are treating behavioral health like we would any other medical issue in addressing the delay of care? I think for specifically the Elliot system, what we're looking for is to not only enhance a straightforward process for patients, but actually help patients navigate that. So again, when somebody presents with cancer in our, there's a nurse navigator that helps them navigate through the system. What we hope to do is make things very simple so that when a primary care provider sees a patient who needs behavioral health services and has a kind of a general assessment of what they need, that they're referred to one place. There's not 9 different referrals where they could potentially be referred to. And there's an understanding of what the provider feels that patient needs. Do I need just some reinforcement or an assessment about the medications that the patient is receiving? Do I think this patient really needs long-term psychiatry? Does this patient need higher level of service care beyond what the Elliot is able to provide? And are we able to bridge that patient to those services that they need? So that the provider is seeing the patient, there's a very simple referral. We then have navigators on the other side of that referral to help place the patient where they need to be. I think the other component that we're really focused on is ensuring that all patients, regardless of payer, are able to access services. So, we have a limited number of behavioral health resources just as everybody else, and we count on community partners, both private and the community mental health centers, to help us serve our patients. The challenge is that when there are patients who have potentially Medicaid and they need to see somebody out in the community that only accepts private paying insurance, those patients have a hard time with access. So we want to ensure that we have equal access for patients, regardless of payer, for the behavioral health services that they need. So if we are able to succeed in that, in my opinion, that would be success for our system.
That's fantastic. That opens up a whole host of follow-ons. So let me just take 2, and I'll give you batter's choice here. So to stay with you, Holly, on the payers, that's one thing. And the second is community integration, like working with your partners in the community. They're also struggling, right? We have a large community business, and so we hear their challenges as well. Let's start with the payers just for a second. As you've transformed your service line, how would you say the payers are reacting if they may not even know yet that you've done this because these programs are so longitudinal? But just talk to us a little bit about the payer experience or any learnings that you may have on that lens specifically.
I can start this one.
Great.
In my experience, it seems to me that payers are becoming more aware of the need to provide behavioral health services, which I'm very encouraged by. So it seems that over the past 4 to 5 years, as we have really looked closely at the opportunities to expand services, knowing that we need to do better, insurance companies are also realizing this, and alongside what we're able to provide within our system, it seems that insurance companies are becoming more expansive. I would say that goes more for the private payers more than it does for Medicaid, but we continue to discuss with our lawmakers and our Department of Health and Human Services the need to expand opportunities for patients who are needing behavioral health.
That's great. Kathy, you want to comment, please?
Sure. I think that I would like to be cautiously optimistic about the payers. I think that about at least where we are, and we're still a fee-for-service area of the country. Value-based hasn't really hit us at all here in Texas, and so everything we do is very fee-for-service based. I think that the payers are saying that behavioral health is important. We still have not seen an adjustment in how their coverage may be expanded or reimbursed in a meaningful way that pays for the cost of taking care of patients. So they are talking about it more, but we still haven't seen a lot of change here. I think that one of the things that we have seen in discussions with our payers here is an interest in kind of the full continuum of care. So whether or not we're able to move now that we have it into some different types of arrangements with payers will be yet to be seen.
Great. Thank you both for that. Let's flip the other side to the community integration. So we certainly have CMHCs and FQHCs that varying by state, by payer mix, can be doing well or could be, more than likely challenged in this area. So how have they received this redesign? Anything that you've done differently as you think about those communities? And Kathy, maybe I can ask you to go first on that.
Yeah, Holly may have more to share there. I will tell you that, we are still in the early stages of the work that we're doing here, and we have a very, very strong community health initiative group who is very interested in all the things that we're doing, and they do a lot out in our community. But I will tell you that since we're in such the early stages, we haven't seen a lot of change so far. So maybe Holly can share more about what they're doing in their space.
Great.
Yeah, I will say that one of the most common things that I hear from the providers in our medical group is challenges with people that have behavioral health issues that they're not comfortable managing and the lack of access. So a patient will be admitted to an inpatient unit and discharged with on a certain number of medications that perhaps the primary care provider is not comfortable with. And I will say, again, having been in the medical field now for 28 plus years, I think providers have made leaps and bounds in their comfort levels. So I think when there are patients who are on medications or doses that they're not comfortable with, it certainly demands and deserves a specialty opinion. So one of the things that I've heard is the challenge with managing those patients, because patients will come out of their inpatient stay, and then they will be referred to either a community mental health center or one of our psychiatrists for management. and there's a delay in access to care. And sometimes for the community mental health centers, it can be up to a year. And so those providers, those primary care providers, are left managing patients that they're not comfortable managing on those medications. And I think that we, as probably everywhere else in the country, are challenged with resources. And, you know, the last I heard, our community mental health center had 75 clinical openings, right? So it's a challenge for the community. And I think what we've realized as a system is that we need to put something in place to manage those patients while they're waiting to get into community mental health resources. So we are actually planning on creating what we're calling a stability clinic, so that when patients need a higher level of care, there's a clear understanding that's communicated to the patient that a higher level of care is needed, but because of the delay in access, we are going to help manage these patients until they can access the resources that they need. And in my opinion, it's been a huge learning curve for everybody across the system, including primary care providers, to really understand what community mental health centers offer that is different from what our behavioral health practice offers, because they may not understand that, you know, and I don't think that they you know, why do we have to refer somebody to community mental health if we have psychiatrists? But there are definitely different resources available in the community. And so we're trying to not only educate our providers about what the different levels of care, you know, about the different levels of care, but also help them communicate with their patients that you may be seeing our behavioral health team for a few months while we bridge you to what you really need. And here is the reason that you need these services. So I think there's a ton of education that has been required and will continue to be part of the process. And also enabling the providers to help explain to patients what they actually need, so that the patients can understand, you know, you're going to be with somebody for 3 months temporarily, but you are then going to be transitioned to another level of care. So it's been a fascinating process, I think, overall. And one thing that we've done, which has been very successful, is create a group of primary care providers working with our behavioral health providers so that they understand what each practice is struggling with, you know, so that the behavioral health providers are understanding things from the perspective of primary care and vice versa, to develop systems together to enable to support the patients at the level that they need.
Powerful.
It's powerful. I wrote that down so I can follow up with you later. Stability clinics, that sounds fabulous.
Sounds fabulous is right. That's fantastic. Okay, so thank you, Sarah Bishop, for that question. I'd love to turn it back to the process that you went through. So if you think about how you actually built a cogent plan, you got your team bought in, you took it to your peers on the leadership team, and you got buy-in. This is obviously a practical problem for everybody. So can we hear a little bit of how each of you took that approach and how you got through the internal buy-in to launch your programs? Kathy,
sure, I can start if you'd like. I think the biggest piece that our organization needed to understand was how the gaps or black holes in our system were actually affecting the system and our patients. You know, our strategic initiative, we have a strategy called Vision 2026, and the consumer patient is at the center of that. And so every decision and anytime we're doing any work, we always go straight to how does this affect our patients and our consumers. So we set off to actually understand what was happening in our community to all of these patients, where our employed physicians had diagnoses, you know, of some sort of mental health challenge. Where were they going and what was happening? And it took us some time to really track all that down and really understand what we were losing as an organization and how disconnected the treatment was that these patients were receiving from their primary care physician and how that affected their overall health. So I think that was one of the first things that we did as an organization. The second thing was that, you know, it's great to have a lot of data, but understanding and having a good partner to help you, right? The question of, do we build it? Do we buy it? is a big question, and there's financial decisions involved there, there's infrastructure decisions that are involved there. And so as we presented to our organization to try and get buy-in, we also had to really do a lot of research on who's the partner that we are going to have to help us address this issue. And being able to share that with the organization and getting their buy-in to that piece. And then finally, you know, as we think about buy-in, it's not just a one-time thing. You know, you can get buy-in at the beginning, but then it's accountability, right? You've got to put your money where your mouth is. You've got to stay accountable to the business case. You've got to show the stakeholders that you are, you know, you're actually doing the promises that you made. And in particular, I think the two big there's probably three big stakeholders in our organization. One is the physicians. This was really important to the physicians to have this additional piece that would complete our continuum of care. So they're the first. Second is going to be obviously to the patients, because up till now, we released them kind of into the wild with no way to lasso them back or to be able to have the physicians where their medical home was have information about their treatment. And then finally, the last stakeholder is really going to be our organization, right? So that they understand how we are staying accountable and what the outcomes are that we promised and how we are achieving them. So that's kind of how we approach it in our organization.
Yeah, interestingly, over the past, well, I will say that I try to meet with each of our medical group providers at least yearly to understand what their challenges are. And there's always themes that have evolved over the years. So a while back, it was prior authorizations, right? Right now, the very common theme for almost every primary care provider I would speak with was access to behavioral health. And when you think about how that was challenging the practices. So for instance, a provider sees somebody for behavioral health and it's kind of squeezed in at the end of the day because the triage nurse isn't really sure if it's emergent or not. And then the providers are kind of overwhelmed with providing the patients with resources that they potentially may need. And when there's a 60-day wait to even get an intake with our behavioral health providers, those patients are calling the office on a regular basis. I need to get in, I need to get in, I need to get in. And so not only was behavioral health overwhelming to the providers, it was overwhelming the front staff. It was overwhelming. It's been overwhelming to the triage nurses. You know, and if you think about, you know, kind of eliminating all of those steps, if you're able to connect somebody right away with somebody who can assess the severity of their problem and direct them to treatment, you would potentially avoid the vicious cycle of all of the phone calls and visits to the primary care provider. On the other side of the system is the emergency room, which still to this day, we tend to have 10 to 12 patients boarding, waiting for behavioral health beds. You know, some patients need to be in the ER, but if somebody's not really sure what to do with a patient and they direct them to the ER, the patient ends up staying there for 12 hours, 24 hours, sometimes a couple of weeks, which we want to avoid. And so making sure that we were putting an assessment in place that would allow a patient to be appropriately evaluated without just that flip, oh, I'm not sure and I'm uncomfortable and I'm scared, so I'm going to send the patient to the ER. So if you think about how that impacts the system as a whole, it impacts patient access, it impacts provider and staff satisfaction, it impacts the satisfaction for the providers in the emergency room and the patient satisfaction in the emergency room. And so we really brought this to senior leadership as something that is impacting the system. And if we were going to improve as a whole, we really need to address behavioral health, because if a practice feels uncomfortable and then sends a patient to the ER, and then the emergency room provider is kind of keeping an eye on that patient for 3 days, even though they don't really need to be there, but we need to find a better disposition for them, that's not really satisfying anybody, and that's not really utilizing our resources to the best ability that we can. So that's where I think that we were able to help to engage our senior leadership in really bolstering our outpatient support, in addition to the fact that we all know it's a competitive world out there, and we're all hoping to attract providers, attract triage nurses, attract medical assistants. And so if we can take a situation that is causing a significant amount of stress and manage it better, we hope that we will be on people's top of mind of a place where they want to work and deliver care.
That's great. That's great. So I'm gonna use this opportunity to jump into a topic, because you just said it out loud, Holly, that when we went into COVID, certainly virtual care existed well before COVID, and it accelerated dramatically. And then following COVID, we've returned to facilities and on-premise. Behavioral health is probably the outlier there in terms of the number of consults and encounters that still happen virtually. And so now I've heard from both of you, both in person and here, about balance. So maybe talk to us about how you think about the balance of virtual and physical, and both in building your programs, but also sustaining them. Maybe we could just start there.
Sure, I'll start. I know this will be a big surprise to everybody, but Texas is a big state, right? We have a lot of spread out communities. It is longer to go from Texas it's longer for me to go to El Paso than it is to go from El Paso to California. So we're a very large state. We have a lot of rural communities. No matter what insights organization you look at, the virtual behavioral health is the largest growing behavioral health offering for the next 10 years, right? Everyone agrees. And virtual health is how we're going to reach the masses, whether that be in the rural areas, the underserved communities, and just honestly, people who are looking to virtual offerings for convenience sake. So as we think about how we're going to provide services, in my mind, and even as the virtual leader, right, I think that there is a certain set of patients that virtual does not work for. And so you have to be able to provide a hybrid approach that offers some sort of bricks and mortar as a nice kind of connection, but also being able to have robust virtual offerings for those who need it, and what makes sense, so that there can be that great integration to the longitudinal care of the patient. The great thing about virtual is that, with the bricks and mortar offering, it's you and the provider, or maybe the immediate providers. When you have a virtual offering, now you can bring in multiple providers or specialists. You can bring in family when appropriate. It just gives you a lot of opportunity to care for the patients in different ways. So for us, we think that virtual is going to be a really important part of particularly our behavioral health service line. I think there's going to be a lot of unknowns. There's a lot of regulatory questions that still have to be answered. We all know what they are here. We all know about, us sitting on pins and needles for a lot of things that are set to expire this year. And I think that what our government sees is going to be a really important thing for us to continue in order to address the mental health challenges of people across the country. But just here in the Texas area, without virtual care, there will be a lot of people who are not cared for, that are struggling either with the transportation, with access, or just with, geography challenges. So it is an important component that we will supplement where necessary.
Yeah, and Kathy, I love that you're from Texas and I'm from New Hampshire, because you're from a huge state and I'm from a small state. And I'm not originally from here, although, again, I've been here for a very, very long time. But New Hampshire brings its own unique challenges. So I will share that in 2019, before the pandemic struck, we were one of those organizations that thought that our ability to deliver virtual visits was at least 3 to 5 years away. And then COVID struck, and somehow we all across the country were able to kind of develop the ability to deliver virtual care almost overnight. And we didn't know what would happen after, subsequently. We didn't know if people would want to come back into the office. What we found is that, most of our practices that are non-behavioral health, probably 20% is virtual care. But over 80% of our behavioral health practice is virtual. And so there is a hybrid approach. What we found is that it's incredibly successful in delivering care, but also there was a dramatic decrease in our no-show rate for behavioral health visits when we switched to virtual. And what that did in New Hampshire, because again, it's a small state, so there's a small workforce. And what virtual care for behavioral health has allowed us to do is expand beyond our state walls. Now, obviously, any provider who's providing care for a patient in New Hampshire needs to have a New Hampshire state license, but it actually provided us the ability to think outside the box and think, you know what, maybe we have some strictly virtual providers who work for us and are embedded into our medical record, which is where Iris came into play. But actually, it has allowed us to hire additional providers to meet the needs. So we've been able to hire 4 to 5 other providers who are working virtually, who are helping us manage our behavioral health patients, both with therapy as well as with intake. And so really virtual care allowed us to expand beyond our state walls. And again, in a state that, it's a relatively small population, and the healthcare workforce is even smaller, and we're all the health systems throughout the state are vying for the same people. It's really been a wonderful advantage for us to kind of think outside the box and utilize people who are outside of our state to help us with our behavioral health care. It's been a game changer for us. I mean, again, we've gone from a 60-day wait for an intake to now we can do an intake really within 1 to 3 business days, and that's because of telehealth.
It's great data point. Let's take this one level down, and then we'll bring this home. You're managing a large, complex physician group, and you have people that show up in a building every day and see each other, and you have these virtual providers that are members of care teams. And so can you just talk a little bit about the cohesion and how you think about forming that community of practice, if you will? And Holly, maybe you can start us on this one.
Sure. I mean, I think one of the most important things that we have done and what helps us is that obviously even people who are outside of our state are embedded into our electronic medical record. So our providers don't really even know if somebody's virtual or not. Our primary care docs, they see the same notes from people regardless of they may be working from California or they're working here in Manchester, New Hampshire. And in addition, we've created collaborative sessions so that, for instance, our licensed social worker team and therapist team do case collaborations weekly. For those people who are working remotely, we include them. And honestly, because so much behavioral health is remote now, they're all remote anyway, even though some people may be 5 miles from here and some people may be 2,000 miles from here. But we've ensured that they're all on a collaborative team so that they can provide feedback, share ideas. And I think that's definitely key to creating this team. In addition, there needs to be some co-management because certain patients need to be seen right now, and the regulations could change, we don't know, but some patients need to be seen in person at least once a year. So having that team work together is something that we learned was really important from the beginning.
Wonderful. Thank you.
What I'll say, Andy, is I think that is an ongoing, I think that's something that will never end. I think there will always be able to be better collaboration no matter how good it is. And where we started was making sure that our physicians, our employed physicians, were involved in the design of what we were creating. Because if you leave them out of that part, then you've set yourself up for failure, and we did not want to do that. So we had some really good collaboration with some key physicians as part of the design of what we were doing, and they continue to be involved. And so I think that's a key issue. And I agree with Holly, right? Our physicians don't know who's remote and who's not and where they're working from or what they're doing. What they do care about is that our providers are all documenting in a way where they can have conversations and they can communicate with each other when necessary and ask questions where they need to. And so ongoing training, I think, culture building is something that we will continue to do to make sure that we maintain that and that people feel good about how it's all working together.
Outstanding. Thank you. So the last question would be, what advice do you have for your peers? We're here, and the folks will see this later. If you were to advise somebody who's considering making this journey, and Kathy, you can lead us off, and Holly, you can bring us home. What advice do you have for your peers?
I think the first thing is do it for the right reasons and understand the problem you're trying to solve. Because if you don't understand the problem you're trying to solve, you'll be chasing a lot of things that you don't need to be chasing. I think as part of that, right, be creative in how you can serve your community. You know, I think Holly, you know, doing some different things in her area than we're doing in ours. Our communities are different. And I think thinking outside of the box and understanding who you can partner with is important. I would make sure you understand your billing and payer constraints, because if you don't and you have surprises on the other end, then it's a bad day. so definitely understand that. And then finally, I think the buy-in at the highest level of your organization is going to be important, right? Utilize your influence and your relationship so that you can get that buy-in and have champions at the highest level of your organization that support the work that you're trying to achieve.
Excellent.
Yeah, I would say for me, the most important parts, number one, has been humble inquiry, you know, by asking questions from various stakeholders, and not just the primary care providers, from behavioral health, from the PSRs, from the triage nurses, understanding what their challenges are. That is first. And, you know, I think that when it comes time to make, you know, presenting a program for senior leadership, you know, I know that if our behavioral health workflow, you know, keeps even one provider in our system because they wouldn't want to lose those resources, you know, that's worth its weight in gold. You know, aside from all of the concepts of better care for patients and, you know, patient satisfaction, provider satisfaction, you know, creating a system where, you know, people want to work because they know that, you know, their concerns will be listened to and there's some response to those. I think that's been really important for me. And again, I think humble inquiry for all stakeholders is really important because, you know, our perspective, what we learned through this, the perspectives of behavioral health providers were very different from the perspective of primary care providers. And it was important to listen to what all of their challenges have been. The other aspect that I think is really important is data collection. I think was really helpful for us to actually be able to analyze the number of behavioral health calls and visits that we do, the amount of time that it was taking, understanding how that can be converted into, you know, I hate to say it, but billable time. You know, there was a lot of time, you know, if you take 100,000 calls and, you know, 1 out of 5 of them, at least 1 out of 5 is behavioral health and it's taking 30 minutes. That's a lot of time. You know, that converts into a certain number of FTEs. So I think gathering data regarding length of time till appointment and, you know, the amount of phone calls that are, you know, being received and the amount of questions and the number of referrals, I think all of that was really imperative in helping us to build a business plan that allowed for this additional investment in behavioral health.
Wonderful. Well, ladies, thank you very much for your thoughts and all your work. Congratulations on your success. And, you know, everyone in your organization appreciates your leadership. It's not an easy journey to get your programs off the ground. And for the audience, thank you for all the questions. We couldn't get to everybody's question, but we will work to follow up in email and give you some kind of a perspective on an answer. With that, we're going to wrap. Thank you, everybody, for attending. And thank you, Dr. Mintz and Kathy, for being gracious with your time. We know you have so many things going on. Look forward to seeing you soon.
Thanks for allowing us to participate. Thank you.
Me too. Thank you.
And thank you all so much. And we, again, want to thank Andy, Kathy, and Holly for an excellent presentation, and Iris Telehealth for sponsoring today's webinar. And if you're interested in learning more about the content presented today, please feel free to check out the resources section on your webinar console, and then you can fill out the post-webinar survey. Thank you again, everyone, for joining us today, and we hope you have a wonderful afternoon.